we'll go to the part 2 of this endometriosis. In part 2 we'll go about the clinical features. Okay, so what are the clinical features that we have? Okay, first thing, as I told you in the last video, the first word that I told you was there are two major complaints of endometriosis. One is pain and next is infertility. So first we'll discuss about the pain. So what are the types of pain that you can see? Like you can see all the type of pains that you can see in this. That is, one is chronic pelvic pain. And they'll have pain that is secondary dysmenorrhea. So what do you mean by secondary dysmenorrhea? So this secondary dysmenorrhea is basically they'll have painful menstruation. This painful menstruation starts 1 to 2 days before. Menstruating. Okay, and basically in the secondary dysmenorrhea, even though if you give treatment as NSAIDs or oral contraceptive pills, this both doesn't work. Because they don't work, so that cannot be given. So secondary dysmenorrhea is a second important thing that you can see. And third is dyspareunia. That is, this dyspareunia is basically a painful coitus that happens because in the previous video I've told you the nodules are present in between the to be specific, I'll write here. This is the uterus and here is the rectum, and I told you the nodules are present here. So in pervaginal examination, you can identify these tender nodules can be seen. So what happens, once there's a coitus, what happens, repeatedly these tender nodules come in contact and they'll have severe pain. So that's called as dyspareunia. After dyspareunia, what are the other things that you can see is dyschezia. I told you last time, the painful defecation because of the inflammation in the case of deep lesions. So this dyspareunia and dyschezia, you can indirectly tell, you can most commonly see in the case of deep lesions, deep endometrial lesions, and of course even dysuria as well. Okay, and then sciatica. Sometimes what happens is endometrial tissue even involves the sciatic nerve. That's why there is a sciatica. And this is the first symptom I told you. What is the second thing is infertility. Infertility can be seen. And third thing is menstrual symptoms. Okay, menstrual symptoms. What are the things that you can see in the case of menstrual symptoms? First one is HMB, heavy menstrual bleeding, and next is premenstrual spotting. Premenstrual spotting can be seen. Okay, next, fourth is gastrointestinal symptoms. So in this, I told you constipation is there, diarrhea is there, tenesmus will be there, dyschezia will be there, hematochezia. See, dyschezia is nothing but called painful defecation. Hematochezia is blood in stools. Important. You people must be knowing because surgery, this comes out. Dyschezia. And next is hematochezia. This is blood in stools and this is pain during defecation. And they'll have colicky pain, and in the case of they'll have urinary symptoms as well. So these are not generally asked in the case of exams, but still for completion purpose. So they'll have loin pain, backache, abdominal pain, urinary frequency will be there, urgency. Important thing is hematuria in the case of deep lesions, and of course suprapubic pain, chronic fatigue will be there. And next is respiratory symptoms. If this is basically wherever the endometrial tissue is there, so they will have symptoms like they'll have cyclical chest pain during menstruation because this is hormonally active. The endometrial tissue which is present in the pleura is hormonally active, so that will have pain during menstruation. So cyclical pain will be there. Cyclical chest pain will be there. Hemoptysis will be there. Hemoptysis, that is during the sputum they will have blood in the sputum, and pneumothorax and dyspnea will be there. Acute abdomen also will be there. So, but what is the MCQ they have asked is what is the classical triad of endometriosis? This is important, guys. Okay, classical triad. As I told you, one is pain. So the pain. Second is infertility. This is what I told you, right? And I think by this time people must be perfect in these two symptoms, pain and infertility. So triad includes three things, but here only two things. There are two type of pains that we have to include. One is dysmenorrhea, next is dyspareunia. So now dysmenorrhea, dyspareunia, and infertility. These are the triad of endometriosis. These are the triad of endometriosis. So, guys, this is an MCQ. So they have asked among the following which is not included in the triad of the endometriosis. Then they might even include as dysgenesia. You might think dysgenesia is also part of endometriosis. Obviously, dysgenesia should be included, but no. Dysmenorrhea, dyspareunia, infertility. These are classical triad of endometriosis. Okay. Next, now causes of the pain. Why the pain occurs in the case of endometriosis, that you have to see. This is an important topic they have asked in your university exam. So first thing is the causes of pain. Why I'm telling about the pain so much is, even in the clinical practice, you should know what is the cause of pain in the case of endometriosis. So what is the cause of pain in the case of endometriosis? If you know, so you can give the treatment accordingly. Okay, so the pain can be initially because of the inflammation, or because of deep seated pain, because of the sciatica. So there are multiple causes of pain in the case of endometriosis. You have to give exact treatment for it. Okay, so the pain will be reduced for that female. Now, so what are the causes? First is, as I told you, pro-inflammatory cytokines, prostaglandins, pro-inflammatory prostaglandins. These are two things. And third one, I told you, nerve involvement, especially the nerve growth. Generally, the endometrial tissue which is there, what happens, that will develop the nerves, and once the nerves are developed inside this, it will become like an isolated island of a proper functional tissue. So what happens, this endometrial tissue will develop its nerves, it develops its blood vessel, everything. So these nerves, once it come in contact with the surrounding fluid which is having inflammatory cells, they'll have severe pain. So the nerve growth in endometric implants, generally it's a observational studies. They have done experimental studies and they have seen this. So this is also one of the reason. And fourth one is, I told you, if it involves the rectovaginal septum or uterosacral ligaments, that also cause pelvic pain. So rectovaginal as well as uterosacral ligaments. And fifth one is peritoneal fluid. I told peritoneal fluid will have a large number of inflammatory cells. And next is pain receptors. Generally, this peritoneum will have pain receptors that will get stimulated. So because of the pain receptors, fluid, they have inflammatory cells. So I'm writing everything so your note should be perfect. The pain receptors will get stimulated in the peritoneum. Stimulation in peritoneum. Okay, and because of adhesions, so that will be stretching. So if, for example, you think this is a uterus, okay, so what happens here, poor adhesions will happen, and that may lead to like this. Okay, because of adhesions. So this will cause the kinking pain. It is pulling the structures, and this will cause adhesions, and this adhesions formation in the peritoneum can cause pains. Okay, so these are all the cause of the pains. So now we'll go about the infertility. So infertility, very important. Infertility, these are the questions asked in NEET as this, guys, and NEET PG also they might ask. Okay, so now I'm telling you, so this is the uterus, this is the fallopian tube, so this is the ovary. And now what happens is, because of the inflammation, all this the function of the tube is lost because of the adhesions. Here adhesions, here adhesions, here poor adhesions will be there. Because of this, what happens, the anatomy, that means this motility of the fallopian tube will be reduced. So the motility is reduced. Because of this, what happens, the ovum pickup is reduced. Ovum pickup will be reduced. And then even if the ovum comes, the zygote, once the zygote formation, the zygote will not go into the uterine cavity. Third thing is, the sperms will not be entering the sperms cannot enter. Okay, sperms cannot be entered. So that is because of why? Because of this adhesions, and sometimes it may lead to multiple inflammation that leads to chronic salpingitis. The chronic salpingitis. So the tubal motility will be reduced, ovum pickup will be reduced, distortion of the tubo-ovarian relations, all the tube and ovarian relations will be reduced. So all because of this reason, mechanical factors. These are nothing but called as mechanical factors, which I told. These are mechanical factors. These mechanical factors are responsible for the infertility in this. And second thing is ovulatory dysfunction. So in ovulatory dysfunction, what will happen is basically the ovary, one thing is the folliculogenesis will not happen properly. The folliculogenesis will not happen properly. And next is ovulation. The ovulation will not happen properly. And next, there is something called as, this we'll study later, LUF, that is luteinized unruptured follicle syndrome. And hyperprolactinemia and luteal phase defect. Luteal phase defect. So these are the ovulatory conditions where it leads to infertility. And next, coming to the biochemical changes. This I've told you some multiple times. What are the biochemical changes that I've told till now? One is increased production of cytokines, prostaglandins, macrophages. Okay, now what happens? Because of this inflammation, what happens? Even the inflammatory cells will target even the sperms. Important. So there will be development of the phagocytosis of the sperms. Phagocytosis. But remember, this is not antibodies against the sperms. It is just phagocytosis. So it is just considered as a organism, and the cells will engulf it. So it is not a anti-sperm antibody. So that's a different condition entirely. And next is immunological factors. What are the immunological factors, guys? One is increase of the autoantibodies. Next is the antibodies against the gametes, just like this. Not specific anti-sperm antibody, that is important. Against gametes, non-specific, okay? Here, very, very important, this is an MCQ which is asked in exam, that is anti-endometrial antibody. This asked in exam. Anti-endometrial antibody can be seen in the case of endometriosis. Make this as a point. And because of this, what happens? The entire uterine cavity, tubes, ovaries, everything is distorted. Now the endometrium is not having a proper cushioning effect to receive the fertilized ovum. So what happens? Because of this, there will be defective fertilization. Defective fertilization. And sixth one is they'll have implantation failure. Okay, now seventh one, this is also one of the cause for the infertility, that is because of the dyspareunia. So they'll have painful coitus. So sometimes the frequent coitus also will be, that means it leads to infrequent coitus. So what are the other complications? Is because of the excessive antibodies, because of excessive inflammation, that leads to spontaneous miscarriage also. Spontaneous miscarriage will be there. And they'll have preterm delivery, fetal growth restriction, and then preeclampsia. These are all the things that you can see. Okay, so these are all the causes for the infertility in the case of endometriosis. Okay, so till here is the infertility cause. These are the other miscellaneous causes, the eventful, like conditions which you can see in the case of the pregnancies, like in the endometriosis condition. Okay, next, clinical examinations. What are the clinical examinations that you can see? See, this endometriosis is an important topic for your university exam of MBBS. It is an important topic for your NEET PG exam. It is an important topic for your postgraduate exam. This is an important topic for your NEET SS exam. This is an important topic for your super specialty. That means even your DM exams as well. DM exam, university, DM or MCH, reproductive medicine topics. This endometriosis is asked like left and right, because nowadays the conditions are more. Okay, so that's why I'm teaching you in detail. So what are the clinical examinations that you can see? See, as I told you, in the superficial lesions, it's very difficult to do the pervaginal examination and to identify the lesions. So they'll not be having any tenderness, you cannot feel in the nodules, nothing. Only thing is they'll have little pain in the lower pelvic region. That means pelvic region, lower abdomen or pelvic region. Okay, so general clinical examinations is not so fruitful in getting the outcomes in the case of the superficial lesions. Okay, and when you see the general physical examination, they'll be normal. General physical examination is normal only. They'll not have any anemia or something like that. Second thing, in the superficial lesions, you can't identify anything, just as I told you. And third thing is, if there is a ovarian endometriosis, as I told you, ovarian endometriosis, so they'll have adnexal mass. Adnexal mass. That means in the fornix, once you do pervaginal examination in the fornixes, you can see the fullness. Okay. Next, on per speculum examination, you can see large bluish black puckered endometric lesions on the vulva and vagina and the cervix. You think this is the cervix and this is the vagina. So here you can see all the lesions like this. This is the endometriotic lesions which has been present on the vagina, on the vulva, on the external genitalia and on the cervix. So this can be seen on the per speculum examination. And next, in the bimanual examination, I hope you people know what is bimanual examination. You keep the one hand inside the vagina and one hand on the abdomen. In the bimanual examination, what you can see is, you can see that tender nodularity. That's what I was studying from then. Tender nodularity. Tender nodularity can be seen. Okay, this tender nodularity can be seen, and this will give a feel, a special feel called as cobblestone feel. The cobblestone feel can be seen in the pouch of Douglas and even in the uterosacral ligaments. So the adnexal mass can be seen in the case of ovarian endometrioma, and the nodules can be seen in the case of this fornix examinations. Okay, and uterus. The classical thing that you can see here is uterus will be retroverted and fixed. This is important, guys. Retroverted and fixed will be there in the case of the endometriosis. This is how you can differentiate it from the other conditions. I'll tell you what are those conditions. Okay. And next, sometimes even rectal examination also is done in the case of deep lesions. In the rectal examination, what you can see the tender nodules in the pouch of Douglas. Tender nodules in pouch of Douglas. Okay, tender nodules in pouch of Douglas can be seen. So these are the important things that you have to see. So these are the clinical examinations. What are the differential diagnosis? Of course, if any female is coming to the pelvic pain, lower pelvic pain, you should always suspect about the pelvic inflammatory disease. And second thing is, in the case of ectopic pregnancy, this ectopic pregnancy will actually mimic the endometriosis, but ruptured ectopic, this is MCQ, ruptured ectopic will mimic, it's the other way, ruptured ovarian cyst or in endometrioma will mimic the ruptured ectopic. Okay, that's a differential diagnosis. Okay, next one. See, in pelvic inflammatory disease, generally the uterus is retroverted and fixed in endometriosis, but in pelvic inflammatory disease, it won't be like that. So it will be free and mobile. Okay, So how can you identify the pelvic inflammatory disease? They'll have fever, raised CRP, inflammatory mediators will be raised here also. And in the pelvic inflammatory disease, in the laparoscopy, you can see the flimsy adhesions, whereas in the case of endometriosis, you can see the nodules. And this flame shaped, red flame shaped lesions or bluish or blackish or white lesions can be seen. Okay. And third thing is leiomyoma. See, leiomyoma is nothing but called fibroid. This leiomyoma is painless and mobile. Okay. And next, ovarian malignancy. Ovarian. This ovarian malignancy, what I am telling is, some here also in ovarian malignancy, in part vaginal examination, you can see there is a fullness in the fornix, but it won't be tender. There will be painless. Okay. And even in the rectal cancer also, this is very rare, but rectal cancer. Also, sometimes it will mimic, like if there is endometriotic lesions which has been infiltrated into the rectum, that will mimic as rectal carcinoma because of bleeding. But this will be painful. Endometriosis, rectal carcinoma will be painless. That is the only thing which differentiating this one on. Okay. And pelvic congestions will be there. There's something called as pelvic congestion syndrome that also mimic the endometriosis. And of course, post-operative pain, very rare. Okay. And other miscellaneous conditions, not much of important, like ulcerative colitis, Crohn's, and then irritable bowel syndrome, all this. These are all the other differential diagnoses. Okay. So what is the investigations that you do? Investigations. What are the investigations that you do, guys? The first thing is we do CBC, like we do complete blood count, and we check for the beta HCG. Why beta HCG? To rule out the ectopic pregnancy. Okay. And CRP, ESR, to see if there's a sepsis, patient is in sepsis or no. And specific test, what I want to tell you, this is the things which they have asked in exam. Specific test, first one is CA125. What is CA125? It's a glycoprotein. It's a glycoprotein and cell surface antigen. Guys, this CA125, as we tell CA125 as undergraduate students or postgraduate students, first thing that comes in our mind is CA ovary, that is epithelial cell tumors, as we know. But CA125 will also be raised in the case of endometriosis. Okay. So how much it will be raised? What is the normal value? Normal value, we know that it is just 35 units per ml. This is the normal value. But it will go up to 200 units per ml in the case of endometriosis. In the case of CA ovary, it will go up to 1000 units per ml. Okay. And for the other conditions, you can see even in the case of tuberculosis. In the tuberculosis also, you can see raised CA125. Okay. Now, this is a NEET SS question they have asked. NEET SS. There is something called ESHRE, that is, you know, that European Society of Human Reproduction and Embryology. 2022 they've come with the guidelines, and RCOG, this everyone knows. 2018 they've come with the guidelines that generally no biomarker is required for diagnosis of endometriosis. This is true or false statement which is asked in the case of NEET SS, guys. ESHRE they have asked, what is the recent ESHRE guidelines regarding the biomarkers of endometriosis? It is not recent, like in recently they have told it is not recommended use of biomarkers to diagnose the endometriosis. Okay. So now, what are the other biomarkers is, there is something called miRNA. It's a non-invasive test. It's a non-invasive test which is like still under development. It is still under development for diagnosis of endometriosis. So this is an MCQ which is asked in FMG? This is an important question. They've asked in FMG and NEET also they've asked NEET PG. Recently MIRNA they are used. Okay, but FMG they've asked multiple times. Okay, so this is about the blood markers, and next we'll go for the diagnostic test. Okay, this is the blood test. This is a diagnostic test. First thing is USG. In USG there are two types. One is TAS, transabdominal scan, and transvaginal scan. So here transvaginal scan is very much used because it has the very high sensitivity as well as the specificity. Okay, so what are the things that we'll see? Okay, so this transvaginal scan, what as I told you, it has very high sensitivity. So almost the sensitivity is about 90% sensitivity and 100% specificity. So this was asked in exam. 100% specificity in endometriosis can be seen in the case of transvaginal scan. In which conditions is, first thing is to identify the nodules. Second thing is endometrioma. Okay. So nodules and endometrioma can be identified with a great sensitivity and specificity. And as you know, color Doppler. Color Doppler is used to identify the vascularity of the lesions. So if there's a vascularity, I told you it must be a deep lesions. So deep lesions. So deep lesions can be identified. But USG, however, it is not so superiorly used. But currently we are using is MRI. Okay. So CT is not of that great use in the case of endometriosis. Okay, not that great useful modality for endometriosis. MRI is generally used nowadays. Okay, this MRI is so good that it can even identify the lesion of more than 1 centimeter also. 1 centimeter also it is used to identify. See, this is an image. This is a transvaginal scan. Okay, this transvaginal scan. These are the structures that you can see. This is nothing but called as endometrioma. That is ovarian endometriosis. So here, what can you see? Diffuse low level echoes. That is basically a ground glass. Okay, diffuse low level echoes, that is ground glass appearance, can be seen. This is a TV scan of endometrioma of the left ovary. Okay, next, endoscopies. As you know, laparoscopy is used to identify the superficial lesions. That is what I have told you before. Okay, now initially what they used to do is laparoscopy was the gold standard for the diagnosis of endometriosis, but now recently the ESHRA 2022 they told only in specific conditions you have to do laparoscopy. This is not a gold standard to diagnose it. Okay, so in which conditions you have to do laparoscopy? Those who have negative image result. Okay, that means there is nothing you can see in the case of MRI, CT or USG. Then you have to do. And those have started with empirical treatment and still they are not having any relief with the symptoms. So empirical treatment unsuccessful. Then only you are supposed to do this laparoscopy. So this is an MCQ, guys. Important. Okay, then only you are supposed to do the laparoscopy. Okay, so now what are the things that you can see in the case of endometriosis? Is first one is endometrioma. Second thing is superficial lesions, red lesions or pink lesions, clear lesions, white lesions, yellow lesions, black lesions, all the color of lesions can be seen. And there's something called stellate lesions, like it appears like a star, like this. Okay, so stellate lesions can be seen. So like this, stellate lesions can be seen. So all these things, sometimes holes, like Endometriosis, if you just Google in the internet, you can see like some hundreds of images that you can see. All these lesions can be identified in the case of laparoscopy. Okay, so these dark lesions which I told you before, like blue and black intermediate lesions, is nothing but called as hemosiderin. Okay, this hemosiderin is responsible for the black or blue lesions in the case of endometriosis. Okay, so now comes the laparoscopy. What is the sensitivity and specificity? There I told you 90 and 100. Here it is 97% sensitivity and 95% specificity. Guys, MCQ comes here. I told you here what is the percentage. 90% sensitivity, that means sensitivity is less, specificity is high. But whereas here the sensitivity is high, specificity is less when compared to that of transvaginal scan. Okay, so you can make a list here: transvaginal scan and laparoscopy. Sensitivity is less, specificity is more. Here it is more and less. Okay, that is how we can remember this one. And next we do hysteroscopy as well. Hysteroscopy we do, and sigmoidoscopy, cystoscopy, based on the lesions. Okay, what are the things? Hysteroscopy and sigmoidoscopy. See, the sigmoidoscopy and cystoscopy, all this only if there is a infiltration present. In the case of sigmoid, colon, in the rectum, in the case of bladder, only then we have to do. So this is about the investigations.